Today's lecture is entitled The Gluteal Region, Hip, and Thigh. My name is Carlos Andres Suarez-Quian. I am the author and narrator of this lecture. The objectives for this lecture are listed here. However, I will not read these now. Basically, I will present the muscles of the gluteal region, hip, and thigh, their actions, their innervation, and the vascular supply to this region of the lower limb. Let's begin. The gluteal region is generally considered the thick, fatty area of the buttocks. And you should become familiar with surface projections indicated in the slide and should be able to palpate these structures in a patient. They will help guide you while performing physical exams and keep you from injuring major nerves of the lower limb if you ever administer an intramuscular injection. Removing the skin exposes the thick, fatty superficial fascia. The superficial nerves of this region are known as the cluneal nerves and entail the superior, middle, and inferior cluneal nerves. The nerves are strictly sensory and be the source of much pain if you are forcibly struck in the gluteal region. Think of spanking of children in days gone by. Fortunately, there was little chance of injury to the child, and the practice ceased in most public schools, although corporal punishment is still legal in 19 states. Let's now describe the muscles that bring about action at the hip joint, some of which will be the muscles found in the gluteal region. Remember the actions that take part at the hip joint. They include flexion and extension, shown by moving the thigh anteriorly or posteriorly, respectively. Lateral and medial rotation, where the thigh turns inwards or outwards within the acetabulum. And finally, there is abduction and adduction of the thigh, when the thigh is moved away from the sagittal plane and then brought back towards it, respectively. Let's look at the muscles that bring about these actions. After removing the thick layer of superficial fascia from the gluteal region, we observe the gluteal fascia covering the gluteus medius and the iliotibial tract containing the tensor fascia lata. And of course, the gluteus maximus, the principal muscle that extends the thigh. Muscles located on the back of the thigh can also extend the thigh. Three muscles listed here, collectively called the hamstrings, are able to extend the thigh. These are the long head of the biceps femoris, the semitendinosus, and the semimembranosus. The reason that these muscles function as such is that they take their origin from the ischial tuberosity on the hip bone and span the hip joint. Hence, when the muscles contract, they extend the thigh posteriorly. There's one other muscle, not visible in the slide, that can also extend the thigh. This is the hamstring portion of the adductor magnus. I will describe this muscle shortly. The opposite action to extension is flexion. And here we see two muscles on the anterior of the thigh, the rectus femoris and the sartorius, that act to flex the hip. For example, when you do a crunch. Again, the reason that these muscles are capable of flexing the thigh is that their proximal origin is on one side of the hip joint and the other is distal to the hip joint. Our strongest hip flexor, however, is the iliopsoas, a muscle we observed previously when we studied the muscles of the hip. Here, we see the distal portion of the muscle forming the floor of the femoral triangle region, but understand that this is one of the muscles that represents our core and is responsible for flexion of our hips. Moreover, I want to emphasize that in this lecture, I am focusing on the muscles that are principally responsible for the action being discussed. For example, depending on which gross anatomy book you read, the adductor brevis and gracilis and pectineus all have the ability to flex the thigh. However, These are minor actions of these muscles, and I have chosen for clarity's sake to omit them here. Let me now focus on the sartorius because it is an interesting muscle. Sartorius means tailor in Latin, and it is the reason the muscle is so called. It is the action of the muscle that grants it its name. Why is that? Because the muscle can flex the hip joint, abduct it, and also because it extends to the leg, it is able to flex the knee. Note here that I use the term extends to the leg. I could have easily used spans to the leg. I was relating the length of the muscle, not referring to its motion. But why call it the tailor's muscle? Because flexing and abducting the hip and flexing the knee is precisely what a tailor would do to create a lap onto which to sew. Try it now yourself and mimic the action of the sartorius. Finally, if you happen to check whether the sartorius produces lateral hip rotation in our textbook, Gray's Anatomy, you will see that it is not listed. In every anatomy textbook I have ever read, however, this action is always listed for the muscle, and indeed, it is one of the actions that grants the muscle its name. We now move to examine the muscles that cause lateral rotation of the hip. And for this, we must reflect the gluteus maximus as shown in the slide. And now we can see the 5 lateral rotators that are deep to the gluteus maximus. These are the piriformis, superior gemellus, the obturator internus, the inferior gemellus, and the quadratus femoris. The 6th rotator is the obturator externus. Muscle belly covers the obturator foramen of the pelvis, and its tendon travels posteriorly to the humerus. Together, these muscles are able to rotate the hip laterally, but understand that these muscles are small, and in most individuals, this is not a major action that we take with our hips. This is an action performed mostly by trained athletes. Think ballerinas, for example. Additional muscles that assist with lateral rotation of the hip include the gluteus maximus, the long head of the biceps femoris, and of course, the sartorius. Again, even though I now include these much larger muscles, do not think that the average person can perform significant lateral rotation of the hip. This action requires training. The opposite action to lateral rotation is medial rotation. To see these muscles, we again need to reflect the gluteus maximus to observe the gluteus medius, which we then reflect to observe the gluteus minimus. Together, the gluteus medius and minimus produce medial rotation of the hip. And, as you can observe, these muscles are much larger than the lateral rotators. Hence, one would think you are capable of producing medial rotation much more readily than lateral rotation at the hip. But this is not the case. Although the muscles are larger, they do not have much mechanical advantage in their attachments to produce important movements. Again, these actions are performed by trained athletes. However, if asked to list all the muscles capable of producing medial rotation, then we must add the tensor fasciae lata, the semitendinoses, and the semimembranoses. In addition, we will look at the adductors of the thigh shortly, and these also help with medial rotation of the hip joint. The last 2 movements to consider are abduction and adduction at the hip. Here, we address the muscles that produce abduction. And as before, we show the gluteus medius and gluteus minimus, the 2 principal muscles responsible for abduction of the hip. And to complete the picture, when the thighs flex, 4 of the small lateral rotators, shown in the slide, are also capable of abducting the thigh. As well, Most anatomists will list the tensor fascia lata and the gluteus maximus as exhibiting the ability to abduct the thigh. The muscles responsible for adduction are the adductors of the thigh. First, looking at the muscles from medial to lateral, we see the gracilis, the adductor longus, and the pectineus. Reflecting the adductor longus exposes the adductor brevis, and reflecting the adductor brevis exposes the final adductor, the adductor magnus. Having described the muscles that bring about the actions at the hip joint, you know what comes next, their innervation. I showed this slide previously when I described the innervation of the muscles of the pelvis. First, let's look at the innervation of the muscles of the gluteal region. What is important to know is that these muscles are all innervated by nerves arising from the sacral plexus. No exceptions. Yes, if you recall, the sacral plexus sends out parasympathetic fibers and as well innervates the pelvic floor muscles. But for this discussion, we focus on the muscles of the gluteal region that work on the lower limbs. The specific nerve to a specific muscle is rather straightforward. The nerve that innervates the obturator internus, for example, will be known as a nerve to the obturator internus, and so on. So this is not too complicated to learn. But now focus on the superior and inferior gluteal nerves. I will describe their importance shortly as they relate to walking. And we now look at the blood supply to the gluteal region, which we previously described in the lecture in the pelvis, as arising from the internal iliac artery, labeled here. Two branches, the superior and inferior gluteal arteries, accompanied by the corresponding nerves from the sacral plexus, exit the pelvis and are observed in the gluteal region. Their name relative to their position, whether superior or inferior to the piriformis muscle. The superior and inferior gluteal nerves would also sit superior and inferior, respectively, to the piriformis muscle. The inferior gluteal nerve innervates the gluteus maximus, whereas the superior gluteal nerve innervates the gluteus medius and minimus. And why is this important to know? Here, a person is shown from the back, standing up. Both feet are planted on the ground. During walking, as the right foot, for example, is placed on the ground, the tensor fascia lata and the gluteus medius and minimus on the same side contract. Muscle contraction serves to keep the hip on the swing side approximately level. In this manner, the foot is able to clear the ground during normal gait. If there is damage to these muscles on one side during walking, the hip falls on the opposite side. This is called a positive Trendelenburg or dipping or waddling gait, and is a result of injuring the superior gluteal nerves of the contralateral side to which one falls. The superior gluteal nerve is at risk of injury during hip disarticulation. There is an increased incidence of congenital hip disarticulation in females of Northern Italian ancestry, presumably due to a genetic link, although it still remains a mystery as to why this is. The newborn girls are treated early in life with a body cast for nearly a year to remedy the situation. Let's now move to the nerve and blood supply to the thigh. Shown on the slide is the right thigh, from which the skin has been removed to expose the superficial fascia and the underlying fascia lata, the deep fascia of the thigh. Within this layer, we will find the superficial inguinal lymph nodes. All lymph from the lower limb will drain to these nodes. In this superficial layer, we also find the cutaneous nerves of the thigh. Don't worry about memorizing the details from which lumbar plexus nerve they arise. These were the nerves that made your thigh sting when you took an up-close shot of the soccer ball to the thigh when you were asked to form a wall to protect the goal during a free kick. And finally, we see the great saphenous vein. This is the vein that is frequently harvested for coronary bypass surgery. To understand how the blood supply enters the thigh, we need to first focus on the area of the thigh known as the femoral triangle and the femoral sheath shown here. The femoral sheath is an outpocketing of the abdominal fascia that is separated internally into 3 compartments. More on this later. But importantly, note that the femoral nerve is not found within the femoral sheath. This is the principal nerve to the muscles of the anterior thigh. The femoral triangle is now shown on the slide. Note that both the femoral sheath and the femoral nerve are found within the triangle. The superior boundary of the femoral triangle is the inguinal ligament. The lateral border is the sartorius muscle, and its medial border is the adductor longus muscle, partially masked by fascia in the image. Now look at the contents of the 3 compartments of the femoral sheath. Its lateral compartment contains the femoral artery. The middle compartment contains the femoral vein, and the medial compartment is empty. It is called the femoral canal. Well, it is actually not empty. Lymph vessels travel through there, and also there is a lymph node located there called the gland of Cloquet. If you are a fan of medical history, you should look up this gentleman. But it is through the femoral canal that femoral hernias exit into the thigh. These are more common in females, whereas inguinal hernias, you recall, are more common in males. If we clean up the femoral triangle area and dig deeper, we will find that a major artery emerges from the femoral artery, sometimes as big in diameter as the femoral artery itself, and this is called the deep femoral artery. It is from this artery that the blood supply to the head of the femur will emerge, and in general, it is from this artery that perforating branches exit to supply most of the posterior thigh. The femoral artery, in contrast, will supply most of the anterior thigh. It will continue into the back of the knee as a popliteal artery and ultimately serve the leg and the foot. We now reach the last section of this video and describe what are the nerves that supply the numerous muscles we described previously. And fortunately, learning this information is straightforward. This is because the muscles are contained in compartments, and the nerves will generally only innervate the muscles found in that compartment. Here, for example, we have drawn the 3 compartments found in the thigh, in anterior, medial, and posterior compartments. What innervates the muscles found in the anterior compartment? The femoral nerve. What innervates the muscles found in the medial compartment? The adductors of the thigh. The obturator nerve. Finally, what innervates the muscles of the posterior compartment? The sciatic nerve. The only 2 exceptions are the adductor magnus and the biceps femoris. This goes back to evolution in that the adductor magnus is both an adductor and a hamstring, and when these muscles fuse, they retain their innervation. Hence, the adductor magnus is innervated by the obturator and sciatic nerves. The biceps femoris also receives dual innervation. It is both a hamstring and a flexor of the knee. Hence, it will be innervated by the sciatic and the common fibular nerve. This will be discussed further in the next video. To review, I include this table. This is a summary of the action that takes place at the hip and the muscles that bring about these actions. In white are the names of the muscles that principally perform the listed action. In yellow are the muscles that serve an accessory action to these movements. This now concludes this video on movements and muscle actions of the hip.